Recording. So welcome. Thank you very much. Today, Tuesday, sorry, not Tuesday, Sunday, 8th of February, 3 p.m. Sydney time. We're doing this AMC clinical, and I've called this session a practical approach session because I want to talk about the practical tips surrounding most of these scenarios and the issues because much of the advice and much of the guidelines you can always read, but it's the practical tips which I think makes a huge difference. So we'll start in the interest of the time because both myself and Dr. Nisek have got a few cases, and these cases I'm taking a different approach to highlight some of the key points surrounding some of the commonly raised issues during the AMC clinical exam. So without further ado, I think I'll just start and I'll start sharing my screen first so you can see that screen. Okay, so I believe that, okay, my screen is, you're sharing a window on another desktop. Please switch to desktop. Okay, all right. Let me just see what's going on in terms of my screen sharing. There's always a bit of a concern when it comes to screen sharing. Okay. All right. Let's try again. Okay. That's not working. Let's close that. Resume. Okay. Perfect. Finally. All right. I like to see people. That's why I try to have two screens at the same time so I can see people at the same time as I'm running my session. So excuse my little glitches. So welcome again. We'll just start. So basically, tomorrow is a very important date for all of you who are potentially sitting the AMC clinical exam. It's because tomorrow the dates open, and these are the key dates as per the AMC website. I'm sure that you may have oriented yourself with these key dates anyway. At about 10 a.m. tomorrow, the bookings for the pretty much all the way up to August will open. And these are the dates which they have mentioned that you'll be booking for. And you can keep on booking these tests all the way up to 16th of February, close of a business day till 5 p.m. All of it is available on AMC Clinical website. So if you don't know that already, or if you haven't uh, oriented yourself to that process, because there is a process behind it, please do that because there's something interesting about it. But I'll just quickly summarize what's happening. You are going to go and book in a test, but at this time, you are not expected to pay for the AMC clinical. You're actually going to choose 3 dates and you're going to rank them in terms of your priority, date 1, date 2, and date 3. And based on your priority, AMC will decide which date you'll get. There are about 1,000 places. So hopefully, most of the people, the AMC, what they've put on their website, despite the fact that there are 1,000 places, there is going to be a tough competition when it comes to booking the dates. So just be mindful. There was a recommendation on the website itself that uh, come in early. First people who come first get first served in terms of their date allocation. As I said, there is no fee payment at this stage. You do 3 preferences, and if you confirmed a date, you'll get an email from AMC to pay for the exam fee, which is $3,000 for in-person exam at the AMC Test Center in Melbourne. And once you pay the fee, your date is confirmed. That's the process. Now, the second part of this booking process is, what if you don't get into a test? Well, AMC on their website are saying that if you don't get it, then you can do something called expression of interest, or there will be an expression of interest by some process in which you'll be given an option that, oh, somebody's dropped out or somebody want to reschedule, and this is the date which is available. And if that's the case, then you can book your exam according to that. Now, as per AMC, the notification of expression of interest may happen weeks to a month prior to the actual exam date. So this is a bit bit of a touchy point, that how can you mentally prepare when you don't know that you're going to be doing an exam all the way up to a week prior, and when you get a notice, oh, you're actually doing an exam. So I was thinking about it this morning, and I thought, if I was in a same situation, I'll probably tell myself that I'm doing an exam. There's no harm in preparing for an exam. I'll just say for instance, my expression of interest date is around 12th of July. So I'll mentally prepare myself, regardless of what's happening in the background at AMC, that 12th of July is my exam. And if there is an availability and the AMC comes back with the 12th of July, based on the expression of interest or whatever the date might be, at least I'm ready. So pick a date in your mind, dependent of that expression of interest time slot as per month, and then be ready. I know it's not easy, but then if you want to do an exam, that might be the way to go about it, to be mentally prepared and to prepare for the exam in that way. Now, that's what I was talking about in terms of expression of interest. Now, so be ready tomorrow, guys. I'm not sure how many of you are taking the AMC clinical exam, but if you are planning to take it, just first come, first serve. In terms of being strategic about choosing the AMC clinical date, I think everybody may have their own method. Choose them month to month. Maybe if you get a chance, choose them wide spread apart when the dates are available, and see how you go. I mean, I would imagine, I'm not sure, but that is a question that the people might be choosing a same month slot rather than different month slot. I don't know what AMC want you to do or what you want to do, but you may like to choose 1 month, second month. So you may like to choose 1 month in May, 1 month in June, 1 month in July, something like that. Mind you, it doesn't really matter because you'll only get a confirmation once you're confirmed, and then you can pay free, and then it's only spreading apart. If May is very popular, then at least you've expressed interest in terms of June and July as well. So I want you to have the best odds. There are 1,000 seats to get. And check your emails regularly. Make sure it's not going into spam folder, and pay immediately, because if you're not paying immediately, then obviously that spot might go as an expression of interest to someone else. Dr. Nisak, anything that you'd like to highlight from that point of view?
Yeah, absolutely. As you told, like, from when we are booking the dates for the AMC1, AMC MCQ, we usually prefer the dates which are towards the end. And we have the same mindset when we are booking the, AMC clinical exam dates as well.
Yeah.
So that is where everything goes by. And, there is a cluster over there towards the end date. So my recommendation would be to go early in the exam. So if I'm not wrong, the dates are starting from the May.
Mm-hmm.
So just target the early days of the May if you're well prepared. But at the end of the day, it's your decision to make based on how much well you are prepared and what timeline you're expecting on the revision and everything.
That's a very good point. And I think part of it's influenced by the fact that the people are relying on the Telegram and the social media platforms for the recalls in that certain date set. That, look, I might be able to get hold of some recalls, and that might be beneficial to me to get some idea about what cases are coming, or at least what themes are coming. Now, AMC on their website, and there have been different people talking about the recalls, that please don't not rely on recalls in totality. I think that's a more sane way of, because they might tweak the image findings, they might tweak the assessment. Like, they may have the same scenario where the history is asked, but you may get a same scenario in which the emphasis is more on the management or differential diagnosis. So go on with an open mind rather than relying on recall. And we'll talk a little bit more detail about that in the session. In terms of preparation resources, I can often rely on these books or these references as my get-go. As you would know from my previous videos and my discussions, that I think AMC clinical exam is more dependent on your practice, practice in role play, practice on practicing the reading resources rather than reading and memorizing extreme forms of knowledge and then trying to regurgitate them as if you're regurgitating a theory. AMC and I've actually examined UNSW medical student, and what I found is that the closer they are to being a doctor, the better they perform. But when it comes to the regurgitation of theoretical knowledge, that's where things start falling apart, because then you're following a very didactic list, if that makes sense, which is not how this exam is scored. You know, your task oriented score, each task has got a score in which you have to individually pass, and then there's an overall score. And I think the overall score has got a lot more say when it comes to an examiner biases, that if you're not really performing as a doctor, then examiner may not give you an overall score which is a pass, and you may say, oh, I took the history and I asked all the essential questions and I came up to the same right diagnosis as most of the people did. um, but we have seen people who have not been able to pass despite ticking the boxes, because overall they were not presenting themselves as a very well structured or practical doctor. Hence, this exam is much easier to pass for the people who are actually working in the system. Um, so, Handbook of Clinical Assessment, it's given. I think that was when 20 years ago, my get go. I utilized lots of cases, practiced lots of cases, but I utilize Handbook as my guide to role play and utilize the themes rather than going into the specific of the cases. Um, Verified recalls are always a bit of a tricky situation. You may open three different sources with three different variation on the cases. So my recommendation around recalls is not to avoid them. Please don't not avoid recalls. This is how our whole course structure is formatted. We have redesigned the entire course based on the last 2 year recalls. Um, and I would say still use the recalls, but I think focus on recalls as the topics rather than the specific of what is asked in that topic. Just as I was saying that when you're trying to book your exam date towards the latter half of the exam date period, you're relying on the recalls. It's not really the key. It's relying on the theme of that things been asked. For example, there might be an ECG, which we'll discuss shortly. There might be an image of an ultrasound, but the key assessment might be quite different. I think 80%, and I believe based on our previous cohort of people who have successfully passed, they were more proactive when it comes to role play. They have actually learned quite a lot in the role play. And you know about that famous saying that if you want to master something, practice it for 1,000 hours or 1,000 times. I don't know how many times you can practice, but in my experience, AMC Clinical is all about practice. You practice the same thing over and over again, and it'll become a muscle memory. Um, and yeah, there's no supplement by reading extensively rather than practicing. Some of the recommended references are Telly O'Connor textbook and therapeutic guidelines, and obviously Ranscog. I like their therapeutic guidelines as well, and especially RCH children's guidelines as well. These are only references. I don't go and open up a topic, but what I do suggest is when you're doing, say, for instance, a PV bleeding in pregnancy, read around the PV bleeding guidelines from Ranscog website. So they would have most updated guidelines on PV bleeding, and then try read the clinical scenario and try make a link between that guideline and that clinical scenario and see how it matches up and plays out. By doing that, you're saving time in terms of not being completely absorbed by the guideline, which can be often very lengthy. And by reading the scenario, you're actually trying to specifically pick up the points which are being constantly asked in a PV bleeding AMC clinical scenario. And the guideline is just helping you pick up on those specific tasks. And that would be the theme which I was talking about. RCH guideline, again, the same thing. Read the guideline, read the scenario, and do the scenario. Yeah, so that would be my thing. And trust me, guys, I think if you make your groups for practice early on, it will reward you, because as I said, it's all about practicing. And if you're practicing at least 2 or 3 times a week as well, it's more than enough leading up to the 4 or 5 month by the time you get the date. Dr. Nisak, would you like to add anything to that? Or
Yeah, absolutely. As I always tell, like this exam has been contains two component. If you are lacking in any one of those, it might be difficult. Okay, so that's knowledge and the performance. So you have to read the guidelines, you have to get the textbook. So that's your first component, knowledge. Okay, if you are not implementing that knowledge and performing, because in this AMC clinical, along with everything, with the task and everything, there is a time issue as well. Okay, you have to complete all the task in 8 minutes. So you won't able to get an idea assessment if you're not role playing enough. Okay, and that's the thing I want to add on that recall things that Dr. Rizwan just told us. So that's when we use the term like the tunnel vision. Okay, if you're not using the recall smartly, it might, it might harm you rather than benefit you. So that's the thing. If you are getting a recall, let's say, for example, if you are getting a recall of abdominal pain, okay, so we are not just focusing on the abdominal pain and what are the positive finding the candidates have given us. We are focusing on the entire thing, the differential diagnosis, the entire framework of the history and everything. So this is the way we'll be using the recalls as well. Yeah.
okay, no, that's good point. Um, Next up, I'm going to quickly talk about the structure. You all know the structure, so I'm not going to waste a lot of time here. The structure since the May 2024 is exactly the same. 14 plus 2 marked questions, of which 2 are pilot and 4 are recitations. The overall pass is 9 instead of 10, which has been changed in May of 2024. Um, Most of the time you'll get role play actors, but then some of the stations may have ECGs, X-rays, ultrasound pictures, or clinical photographs of rashes that they cannot mimic on the role play actors. Um, Recently, when I was conducting most of the exam for UNSW at Liverpool Hospital, we were utilizing role play actors. So they are very well trained, and I'm actually surprised that how well they can perform. And some of them, when I was talking to them, they actually, uh, most of them, they're professional actors, so they do volunteer for AMC clinic as well, because they are quite good at what they do. They are medical trained performance actors. Some of them are medical students themselves, or they may have finished, and uh, it's good when you are probing them for medical history, they're able to come back with a more authentic, um, information. I remember when I was doing an AIMS, this is related to my fellowship OSCE. I was doing an OSCE scenario with a patient who was a renal transplant patient who had presented with an abdominal pain. He was actually a real patient, and the scenario was more focused towards an acuteness that this is a renal transplant patient who's presented with abdominal pain, and now you're meant to be taking a history, conducting a specific examination, and come up with a management plan. And that became a little bit more artificial because the patient had renal transplant 20 years ago. And here in my mind, I was going through many things that, oh, like the scar of the renal transplant is healed. He doesn't look septic. He looks completely comfortable. And he was saying, oh, he's got this abdominal pain over the flank area. So when the examiner were asking me about the specific question of abdominal pain reason, um, I was not able to completely give them a very realistic view of what was happening. I mean, I managed to pass that station, but one of the things which I did miss, which could happen, which I'm trying to highlight this whole example, was one of the examiner was probing me, oh, is there anything else in the examination finding which you'd like to tell us? I said, no, the examinations was completely inspection-wise normal. Palpation-wise, he was tender in the renal angle area, and there was no external marks of infection or anything like that. What they were specifically asking me to say was, what about the surgical scar? Did you check the surgical scar? And surgical scar was, completely healed 20 years ago. It was not even a part of my assessment in depth, and they were saying, no, you have to make a comment on if the surgical scar was red or inflamed or cellulitic. But that was back in the day. I'm sure that if they want to now portray that, they would have a clinical photograph of a scar to highlight that point. rather than relying on old cases. But just be mentally prepared that the cases could vary. And even though you may be presented with a cold case, the the algorithm in your mind should go through all the steps of examination. Um, no points in guessing this one. It's all about taking history, examination, coming up with the diagnosis, and then talking in terms of management, educating the patient, and counseling the patient. And we know it's medicine, surgery, ops and gynae, pediatrics, and mental health. Most of the scenarios are in hospital, ED in particular. That's the acuteness. ED does not mean that they are unstable cases. ED just means that's where the patients have presented primarily. So that is something which you need to understand, that if the patient is in ED, that does not automatically imply that the patient is unstable. Okay. So just be careful from that point of view. And the GP setting, obviously, you need to think about whether the patient needs to be referred to the hospital or whether the patient needs to be followed up in the GP setting. Um, Anything else that you'd like to add, Dr. Nisak?
Yeah, I think you have covered everything, so nothing to add over here.
Okay. So look, I'm going to talk more practically, and I like to highlight these points through the cases as well. So I'll just skim through that. Uh, these are the things which I still practice when I'm on the floor working in emergency departments. So that's very important. Whenever you are tasked, whenever you're interacting with the patient and you need to take a history, my first rule is please let the patient speak. The patient themselves are trained professional actors to give you as much possible information, refraining some information on the primary information that you've extracted. So, for instance, the patient may have come in with a history of, say, chest pain. The scenario is about the patient has presented with a chest pain after having a recent flight. Now, in your mind, you're already thinking about it could be a pulmonary embolism because they've had a recent travel, or it could be some sort of lower risk tract infection, or contracted overseas, and they may have a pleuritic component of chest pain. So in your mind, you're already sort of judged. But instead of using that judgment or prejudgment to be very specific and direct with your question, park your differential diagnosis and working diagnosis aside and say, okay, I agree that, well, I acknowledge that you've come in with some chest pain. Can you please tell me more about it? So, in that way, let him speak what he wants to say. And from that, choose very specific question for your working diagnosis. So your working diagnosis, as I was saying, that was pulmonary embolism. Then you can go through the specific criteria of pulmonary embolism: recent travel history, any hormonal treatment of HRT or oral contraceptive pill. Have you got any cancer? Have you had recent prolonged hospitalization? So when you ask these questions, you're actually demonstrating the examiner that you're working towards a diagnosis rather than utilizing the information at hand and magically come up with the diagnosis at the end. And to be honest, this is more easier said than done, because overall pass depends on how you demonstrate coming to that diagnosis. So if you want to come to the diagnosis of PE, yes, you read the scenario, you're 90% sure it's PE, but it's your questions related to PE which are going to be marked to establish that, if that makes sense. So those specific questions of the PE are going to be in the marking scheme. Also, um, quick rule outs at the end, because as I said, you've got a differential diagnosis of pneumonia, pneumothorax, acute myocardial infarction. Quick question: any previous history of ischemic heart disease? Is the pain getting worse when you're walking? Uh, have you had any fever or productive cough? Quick rule out, because you've already established the primary diagnosis. The time is up against you. You don't need to, now retake the history of infection, retake the history of AMI. That is not the point. You've only got 4 to 5 minutes when you're taking a history. And if the task is more oriented towards you know asking a question and then giving the diagnosis a second part of the task, then you don't have much time to reflect that. Let me see if I think there are people in here in I should let them ask them to come in automatically. I think they're able to come in automatically. Anyway, um, so that was my history thing. In terms of examination, um, it's easy to get carried away because examination, even if you're asked to examine, say, for instance, the neck of the patient, you may start off with the general physical examination. The patient looks comfortable, or the patient hasn't got any obvious signs of thyrotoxicosis or myxedema or lid lag or anything like that. But you have got a very specific task in hand to examine the neck and the neck only. And especially if the task says examine the neck of the patient. Okay. Um, be systematic and organized. And I often used to think about that. What do they mean by being organized? So I think organization to me is being either top to toe, if you're doing a general physical examination, or if you're doing a joint examination, like hands or something distal towards the proximal, or if you're doing like a lump examination, then following in the surgical mass or lumps and bumps examination format of inspection, palpation, movement, especially when we're talking about thyroid lump. Okay, fine, seeing from the front, from the side, swallowing, inspection, palpation gently, one lobe and then the other lobe, auscultating for any bruit or anything like that, movement with the swallowing, as we talked about. And then the secondary signs in terms of, lymph nodes in the neck and supraclavicle and all that kind of thing. That methodical approach is what will consolidate organization, and the examiner will like that. And keep on interacting with the patient. I like there's been a question that, look, when you're doing the examination scenario, do you say out loud as you're going along because you don't have much time? Everybody has got their own preferential method. When I was examining the medical student, I scored the people highly rated when they were conducting themselves as a doctor on the floor of the hospital, meaning they were conducting the exam. Okay, I'm going to examine the neck. And then what I will quickly do, I'll just have a quick look in front of the neck, just telling the patient, not telling the examiner. They just completely ignored me and just telling the patient, I'm just going to have a quick look at, and then observing. And they were demonstrating what they're doing. Then talking to the patient, okay, I'm just going to gently have a quick feel of your neck and palpating the neck slowly and gradually. What it made me think that they are interacting as a doctor whilst following methodically all the step of the neck or thyroid or lump examination. At the end, they summarize their finding. Now, that's my preference. I think it looks more polished. I think it looks more professional. If you can manage your time well, there is there's nothing like it. Do your examination uninterrupted. You'll be much more fast. You'll be much more thorough. And then you can always reproduce your finding in the last 1 minute. It does not really take long. And sometimes, I was thinking people often worry that, oh, I may not have enough time left to summarize all my findings. Examiners are able to note and make points what you have done. You will not be penalized for saying, oh, he did not do an inspection. Well, they just saw you doing the complete inspection, palpation, percussion, auscultation. So you are not going to lose marks for that, even if you don't talk about it. What you may at the end talk about is what you think about what you've just examined overall. I think it's a benign thyroid lump, benign breast lump. I think it's a hernia. I think this is the primary and secondary findings, and this is my differential diagnosis based on that. So try be more methodical. Speaking to the examiner at the end, I think it looks more polished as opposed to speaking throughout the phase of the examination, which might just you'd be talking to the examiner, talking to the patient. It'll just become. But if you're good at doing that, be my guest. Um, Diagnostic formulation. I think this is the task which is very easy, and it is somewhat not done properly. And exactly the point that I was trying to highlight before, that diagnostic formulation is not about giving the diagnosis. It's about showing that how have you come to the diagnosis. Like asking those specific questions related to PE or related to ischemic heart disease, related to asthma or COPD, those questions which will establish the diagnosis is the key. It's not the other way around, that you have read the scenario, you're 90% sure, and then you give the diagnosis at the end without thinking more about how you establish that diagnosis. And most of the information will be available by the patient when you're taking the history, but some of that information will be obviously deliberately hidden. And when you ask those questions, as I was using that in a way of PE example or pulmonary embolism example, is by asking the patient about specific risks, recent immobilization surgery, and all that. When you ask these questions, you're actually establishing what you want to do, or how you're establishing the diagnosis of PE. Um, and at the end, when you're telling the diagnosis to the patient, avoiding a medical jargon, obviously, needless to say, when you're talking to patient, even if they're doctor, I try to make a note of that I try be very simple. It's not about a fancy language or English. It's just being very simple. You've got a clot in one of the blood vessels of your lungs. Stop. This clot is limiting the flow of blood to your lungs, and hence you're getting a pain. We're going to use a clot busting medication. There's no need to say, you can use the name. We're going to use a clot busting medication like tenecteplase or whatever you're using. But there's no need to use the very medical oriented, that there is a large saddle embolus in your lung, and then explaining it further. Oh, embolus means there's a clot which is dislodged from the back of your deep veins and it's traveled all the way. Try just keep it simple explanation. And if the patient has got question, then explain, rather than explaining it in medical terminology, unless and until there's no way of explaining that in simple layman term. Try keep it simple. um, okay. So I mean, in terms of an example, if you've got a scenario of a chest pain with the ECG showing a STEMI, and the tasks are towards take a focus history and come up with the management, like focus history towards the diagnosis. So the diagnosis is based on the typical ischemic chest pain. Now, you may have a heart score algorithm in your mind, or you may have your own history of ischemic heart disease. Like, is it an exertional chest pain? Is it the chest pain which is central and heavy feeling? Is it getting heavy when you're moving or doing steps or stairs or exerting yourself? Is it radiating into your neck, arm, jaw, or through to your back? That's your own way of establishing ischemia. That's completely fine, but that is showing the examiner towards your diagnostic formulation. Now, if the second part of the task is towards the management, then I think this is very important, that when you're talking about the management, you need to highlight, especially for someone who's got a myocardial infarction, that it's a time critical emergency. So depending on who you're talking to, you might be talking to the patient, you might be talking to a referral medical registrar or cardiologist doing a referral. I've done a scenario to that effect. But you need to highlight this. I've got a time critical emergency in terms of acute myocardial infarction, which is confirmed on typical historical findings from the ECG, typical historical finding from the patient, with exertional chest pain and associated shortness of breath, with the ECG confirming the inferolateral ST elevation myocardial infarction. That seals the deal. That is just enforcing the confidence that you're not thinking about anything else. And then management obviously is talking to the patient, explaining what's happening, giving them adequate analgesia, antiplatelet in terms of clopidogrel and aspirin, and urgent cath if they are within that window. And yeah, what I have observed, and Dr. Nisag might be able to highlight that as well, is that people often go on a very long way establishing the cardiac history, and then they would go and establishing and ruling out a pneumothorax. Then they will go out and explain establishing a P, when the scenario is completely highlighting that this patient is come with the typical symptoms of ischemic sounding chest pain with an ECG confirming. The differentials are no longer relevant. The management aspect is more important after establishing the diagnosis. Okay. So in terms of management, the patient concern is very important. And I remember being a patient in the hospital myself, with someone, or by myself for some reason or injury. And the absolute nightmare of a thing is be unaware of what's going to happen next. So what I've done now deliberately as a part of my job as an emergency doctor, even at my first consultation, after taking the history or completing my examination, I tell the patient what I think is going wrong, what I need to do to establish what's going through my mind. So I would say, okay, look, sir, you've come in, or you've come in after having a fall. I'm thinking that based on the fact that you are quite tender in your hip, you may have had a condition called fractured neck of femur, and I need to do an X-ray to confirm that. But in the meantime, I'll give you an analgesia. We'll do a block to control the pain, and then we'll refer you to orthopedic. You will definitely be requiring an admission. All of this task may take about a few hours to complete. Is that okay with you? It tells them and the relatives everything that you're going to do over the next couple of hours. So the patient concern, if the patient are concerned about there are so many concerns about what's going on with them, what's going to happen next to them. Are they meant to be eating or drinking? There might be concerns about at their home, their kids unattended, their pets unattended. So all of this needing addressing. And it's easy to be methodical and stepwise when you so address the medical concern, address any social concerns, um, and using a simple language. As I said, whenever you talk to the patient, you don't have to come up with a jargon. And uh, it's also very helpful when you're talking about, is there all right with you? If that's, does that make sense? Do you need any more explanation towards what I've already done? So that involve the patient in a decision making process, rather than just telling them that this is what I think is wrong, this is what I'm going to do, and then I'm going to go away for the rest of the day and I'm not going to be available. So ask them if there's any further thing that they want to know. Okay, and for example, I mean, I was looking at this diabetes. For example, if the patient has been recently diagnosed with diabetes, how do you break it down in a very simple way? So you have to explain to them, and sometimes people often ask me how to break the diagnosis of diabetes. Do I have to, because everybody understand diabetes, everybody understand insulin and oral hypoglycemic agent. Do I have to really go down to the basic? I think it's no harm in going down to the basic, that you've got a condition called diabetes, which is because of the high blood sugar, which might be because of relative or absolute lack of deficiency of insulin in your body. If you say like that, you're actually demonstrating to the examiner that you're actually organized in your mind. There's nothing which is complex for you. Trying to simplify the management is what you're trying to demonstrate it to the examiner. And then you plan, like I'll discuss it with the specialist, how are we going to manage that. It may involve the treatment with medication, insulin, and we'll try to slowly bring your blood sugar down. And then there will be an endocrinology follow-up and a dietitian follow-up. And do you understand what I'm just trying to tell you? And if they have no questions, well, you've done your job in terms of counseling. Okay, so I've got some cases, but before I delve into cases, I'll ask Dr. Nisarg if he's got any way, any practical tips that he would like to share based on our recent cohort of AMC Clinical, and what do you feel about it?
Yeah, absolutely. Yeah. So first of all, let me add to what Dr. Rizwan just told us about the history taking and the physical examination and everything. That's absolutely on point. Okay, I think I don't have anything else to add on that particular side. But along with that, AMC is trying, something new at this moment as well. Like since 2025, we have noticed that there have been some changes in the structures of the performance of the tasks and everything. All right. So what I'm trying to say, rather than the classical case of 4 minutes of history and 4 minutes of your management, they are trying some basic stuff like 6 minutes of history and 2 minutes of your diagnosis on differential. Okay. Now, what they have started introducing new is asking the physical examination. Okay. If I'm not wrong, most of you might be going for the face-to-face examination, and there is one major component, the PFI part, asking physical examination from the examiner. Okay. So we don't actually have to perform the physical examination. We just have to ask those particular tasks. Okay. So AMC has been trying this new thing that there is no longer they are asking you to take history. Okay. There are not much cases, just around 10, 15 cases on that particular side. Okay. So you directly ask the physical examination, then you move on to your diagnosis and the management or your differential diagnosis. Okay. So what I'm trying to say by all of this is you have to understand what is your priority. Okay. So if your second task is your management, At that particular point, asking about the side effect, asking about if patient is already on any medication, past medical history becomes a little bit more important. Okay. But if your second task is mentioning that, please ask, explain the differential diagnosis to the patient as well. Okay. So in that case, you have to make a little bit change to your history, and you have to add the most, vital or important differential. The same example, I would take the same example of the physical examination. If the patient is coming with a chest pain and the shortness of breath, okay, absolutely, we'll assess the chief complaint first. We'll then move on to formulating our provisional diagnosis, asking about all the risk factor of the contraceptive pills, hormone replacement therapy, all that sort of thing. But based on your next task, okay, whether it's management or whether it's your differential, your line of questioning should follow that. Okay. So that's the only thing that I want to add over here. Other than that, Dr. Rizwan has covered everything that is needed for this exam. Yeah.
Okay, I like to do some cases um, which I think you might find interesting, because I have taken a practical approach on how to solve a case, as opposed to just talk about the case and um, but there's some practical deep insights behind that. So let me open this up and take it from there. Um, so this is a case about a 65-year-old male who's presented with a background history of 20-pack year history of smoking, hypertension, and he's now presented to your local emergency department with 1 hour history of chest pain. The initial ECG showed inferior ST elevation myocardial infarction. Your consultant in emergency medicine, in discussion with the cardiologist in your local referral tertiary hospital, have thrombolized the patient with 10 ectoplasm. The patient's ECG and chest pain have both improved. Your consultant has now asked you to refer the patient to the cardiology registrar of the referral hospital. The vitals, stable. 130 by 80 is the blood pressure. 90 per minute is the heart rate. Oxygen saturations are also stable. Your tasks are to refer the patient to the cardiology registrar and explain to the patient and carer about the transfer plan. Now, let's make it an exercise. And this is not, you know, it's just a discussion. But if anyone wants to talk about the first part, referring the patient to the cardiology registrar, what would their approach be? And then we'll try finesse that. I think this is something which is not commonly being done. I'm not sure if it's been tested recently as a pilot station as well, referring the patient to a tertiary hospital or transfer of care of the patient to a ward registrar. This is something which we may not be very useful to or used to. So if anybody wants to volunteer about what particular points they would like to talk about for a patient, then please volunteer. I'll wait. You can unmute yourself. If you can't unmute yourself, just let me know and I'll unmute you. Anyone? Anything. Nobody can be wrong. It's just a discussion. Trust me. It takes a lot of effort to be, oh, Dr. Nadi. Okay, Dr. Nadi.
Yeah, I think I can give it a go.
Wonderful.
I would be doing maybe SBA approach there. Yeah, first of all, introduction of
Mm-hmm.
my patient name, gender, and the age, and the
Mm-hmm.
situation that I am maybe HMO in emergency department,
Mm-hmm.
and then the situation of the patient that briefly. I'm dealing with this patient that diagnosed as, I think here, infero and septal.
Yeah. Okay.
Uh,
Yeah.
yeah, myocardial infarction, and we've already connected with your supervisor, and we've done this management. Um, Now the patient is stable in my situation as part. Then I would like to talk about a bit of background. This patient is in the background history having 20 pack years, and also diagnosed otherwise, I think hypertension. Yeah, hypertension. Yeah, the background. Then I would like to ask about any obviously the assessment with regard to vitals, and the current situation of the patient. Otherwise, then I would like to talk about any recommendation that I will first present our plan from our side, that we need to refer to patient to you now.
Mm-hmm.
We have done the stabilization, but for further management, I'm happy to have your support. And then I will invite him to give me any idea if he has any idea that any recommendation from your side, any other step that you would like to perform from our side before transferring.
Mm-hmm.
Yeah, basically that's my idea, but I understand it should be improved more than that. But as a yeah,
No, that's very
basically,
good. That's very good. I
that's
think you've broadly identified a very good framework, which is an ISBAR method. And obviously, right off the bat, I've put you in a hot spot, and I would not even expect it to come up with a very structured approach. And at least you have got a structure, and you can use that structure if you are in that situation. And that's, thank you very much. That's very good to use a structured approach. So what I did is that, look, um, there's no preferential method of referral. You can use a SOAP method, you can use an ISPAR method, you can use a method which is based on the facts right in front of you. It's entirely up to you. I think, however, it's very important to identify what they want to know and what are the crucial aspects of this transfer. Uh, Trust me, practically speaking, I think this is a very important scenario. And if the AMC clinical committee are not testing this scenario routinely, as a non-pilot for a referral of an admission, they are um, they are going to test it, because this is something that you do routinely when you're working in a hospital. You refer the patients for an admission, you refer the patient for a transfer, and it's often the junior doctors, after the consultant have done the major heavy lifting, who are there to make a transfer. So what are the important aspects? Think about the registrar who is going to accept the patient. What does he want to know? He wants to know about what was. So I'm going to use a SOAP method because that's my method. It doesn't really matter. You can use a ISBAR. And SOAP is, for me, has always been the thing, subjective meaning what the patient presented with, objective meaning what did I find was going on wrong with the patient. Assessment means that what did I do to establish or complete my diagnosis in terms of investigation, which might be in the form of ECG or blood test or whatever it was. And plan, which means that what's going to happen next after what I have already done. I think this is um, something in my mind which may make it easy for the receiving team. So we do a lot of retrieval for sick neonates or sick pediatric patients like with asthma who need to be transferred to Sydney Kids Hospital when I'm working Wollongong Hospital. Or patients, when I was working in Shell Harbour Hospital, where the patient would get thrombolized and then get transferred to Wollongong Hospital for a primary angioplasty, for the angioplasty or reperfusion therapy. So for this patient, what I've done is that I have used, I would like to sort of look at my methodology from the AMC clinical perspective. So, when you get the reading time of 2 minutes, I would like to focus on just three things in my mind outside in those 2 minutes of reading time. What is my task one? And what is my task two? Just try to memorize and keep myself aware of those tasks, because this is what is asked of me. Number two, as I said, SOAP handover. And number three, current analgesia, infusion, treatments, counseling, whatever it is. Okay. So let's do that. So basically, I would say, and I'll bring it back to the case that, look, we've received a patient about an hour ago who presented with a typical ischemic sounding chest pain with an ECG confirming that he is suffering from inferior lateral AMI. I mean, there's an AVL reciprocal change, so I'll call it inferior lateral AMI, depending on whatever the ECG is showing. He presented, since we don't have a reperfusion therapy at our services, my emergency consultant named this and this, refer the patient, discuss the patient with a cardiologist, and we decided on thrombolysis. After going through the contraindication, we thrombolize the patient with tenecteplase at that time, and that led to the immediate resolution of the pain and the ECG changes. So that is going through my management, immediate management. What the plan is that the patient is currently on analgesia. He has received a GTN, or he may have received fentanyl. He may have received morphine. What infusion? If you've got him on some infusions at that time, you can talk about that. If he's got an oxygen going in at that time, you can talk about that. And our plan is that we're going to have him transferred over to your hospital local emergency department via the ambulance with these infusions, with this current management plan, for you to activate your cath lab. So this is a very simple way of doing that. So this is my mind scheme. Okay. Then you can, because obviously you are doing an examination scenario, you start off with the S. So subjectively, what would you like to talk about? This patient presented with 60-minute history of central chest heaviness, which was radiating to his neck based on the historical findings, whatever you've got, and arm. I mean, I don't have that kind of history, but I would just suffice to say, I will say typical sounding chest pain. Okay. Objectively, he looked, now I have to describe how he looked. And there might be some additional information in the scenario or an examination finding. He looked pale, diaphoretic, he looked uncomfortable, he would distressed with pain. And that was my objective assessment. Or if that information is not there, even the initial blood pressure and pulse and heart rate and oxygen saturation, you can say that objectively he had a blood pressure, he was hemodynamically stable, he looked a bit distressed with the central chest pain and a bit diaphoretic. That's my objective assessment. That's just painting a picture for the referral registrar to understand what we faced initially. And then my assessment, the initial ECG confirmed the finding of infерolateral myocardial infarction. He received tenecteplase at that time after receiving the initial analgesia and antiplatelet therapy, clopidogrel and aspirin. And we repeated the ECG 30 minutes after the tenecteplase, which shows that the ST elevation is no longer there in lead 2, 3, and AVF. I'm not talking about the specifics of the ECG, because then it will just go in a completely different direction. That if I start say, oh, he's got 2 mm ST elevation lead 2 and 3 mm ST elevation lead 3, and then also ST elevation and some reciprocal changes in lateral lead AVL and flatten out 1. I won't go there, because then they will start questioning. I could expect some more question from that point of view. I don't want to do that. I would like to just keep it simple. Infralateral ischemia confirmed and reversed after thrombolysis. And the plan, I'm going to be transferring the patient lights and siren through the intensive care paramedics to your local department emergency. I'll talk to the local emergency consultant to give you a call as soon as the patient arrives. Right now, the patient's got 2 large bore cannulas. One of them has got an IV fluid running. The patient is also on oxygen. The patient has received analgesia at this time, fentanyl at this time, GTN at this time. He's also received additionally aspirin, Plavix, glycoprotein 2B, 3B inhibitors, and he's currently pain-free. Now, along with the patient, I've explained the plan to the patient and his carer or wife or whoever it might be, and he has got no questions. Do you have any questions for me to answer? I think if you use this approach, you won't miss out anything. If you want to use the ISBAR approach, that is completely fine, provided you addressing these crucial scenario. Now, second task is explaining to the patient or carer about the transfer management plan, which could be something that we can forget. So that's why I always say in my reading time is task 2, don't forget to counsel the patient, because you can overlook that. So counseling the patient is by an example. So I remember the first time when I was working in emergency and I saw myocardial infarction was in the UK, when I was working with one Irish lady registrar who actually influenced me to become an emergency physician. The way she explained the myocardial infarction to the patient was so simple and easy that it just, and calmly, that was just beautiful. And I said, look, she just has confirmed, and we thrombolized that patient. And she explained to the patient, look, right now, Mr. So-and-so, you are having a heart attack, which means that one of the arteries to your heart muscle is blocked with a clot. Do you understand what I'm saying? He said, yes. Now, what we have done is we have given you a clot busting medication, which will help retain the blood flow to the myocardium or the heart muscles. Now, it's a temporizing solution. We still have to transfer you to a bigger hospital in which they have to take you to a coronary or cath lab. And they will insert a little needle and a catheter to have a look at the blood vessels in a bit more detail as to what's causing that blockage. And you may end up having what we call a small stent, which is like a little plastic tubing to maintain the patency of that blood vessel. Does it make sense? And the patient was like, fine, okay. So we're going to have you transferred over. In the meantime, if you get any pain or any discomfort, you have to please let us know so we can give you analgesia or give you some further treatment. And that's all you have to explain to the patient and ask them at the end, do you have any questions? If you do that, I don't think that you're going to miss out on that scenario at all. You don't have to go super technical. It's all about addressing the elephant in the room, which is talking to the doctor and then explaining similar kind of thing to the patient in a much more simple way. I hope it makes sense without sounding too complicated about it. I think by doing this scenario, maybe Dr. Nadi would agree that it sounds very simple, but when you start talking about it, it's actually not that simple. Dr. Nisak, please share your tips on this. Get us out of our misery.
Yeah, yeah, absolutely. So the clinical has already started testing these cases for the referral.
Okay.
So far, they have tested, I think, 3 or 4 different scenarios, but definitely we're expecting more coming this coming year. And yeah, absolutely, you're on point with this structure, everything, because you are communicating with another medical person, it should be very systematic. The communication should be very clear. Now, as Dr. Rizwan just told, like whatever approach you are comfortable, you can use. Okay, it doesn't matter unless you are in a framework, you are giving all the vital information, and you are, making a clear communication. That's all is needed in this case. Yeah.
Okay, good. Thank you very much for that. I'll move on. I've got one more scenario, and then I'll give. So this is a case which has been asked. The PV bleeding is a very common scenario, as you know, in AMC clinic. It comes in various shapes. The patient being stable, unstable. I don't want to keep the patient unstable, but this is a scenario which I actually saw recently at my work. And having done and practiced so many PV bleeding clinical scenario, I thought it might be good that I have made the clinical scenario with a bit of a twist, which lends itself to a very important, crucial points in history. Because if you don't ask those points, the history would be partially hidden. So that's what I was saying, that you start off when you're taking a history from the patient. Tell me why you're in the hospital today. And then you have to ask a specific question to tweak more information out, which is so much important in this case. If you're not able to extract that information, then you might be left with a scenario which may sound, oh, this patient is seriously sick. Okay. Anyway, if anybody would like to have a go at it, just a few points, pointers, give me some idea what they're thinking about. There's no right and wrong answer. It's just a group exercise. Please, Dr. Stanley, would you like to have a go? I think Dr. Stanley can't hear me. Dr. Asgari, would you like to have a go? Can you hear me? Would you like to give a few points? Can you hear me? Can you hear me? Can everybody hear me? Okay, all right.
Yeah.
Okay, you can hear me. Okay, I was not sure. I was just hoping for a volunteer to talk about few crucial aspects. If anybody would like to have a go. I've got Dr. Stanley on my screen. I've got Dr. Asgari on my screen. I've got Dr. Nadi on my screen. And rest, I don't have a complete list, but if anybody would like to have a go, please be my guest. Okay, that's all right. We'll just start because I think there's a lot of ground to cover in this particular clinical scenario. So look, as I said, this is a scenario that I recently saw. And I'll read the scenario first. 23-year-old lady presents to the hospital after having a medical termination of pregnancy 2 weeks ago at 8 weeks of pregnancy or gestation. After the medical termination of pregnancy, the patient experienced PV bleeding and crampy abdominal pain, which subsided after 5 days. Now, she was having a shower today and experienced heavy PV bleeding with clots and lower abdominal pain. The ultrasound pelvis done in the hospital shows possible cervical hematoma and likely retained products of conception in the uterus. Her pain is subsided after simple analgesia, and a PV bleeding is also reducing. The vitals, blood pressure of 110/60, heart rate of 85, saturation 99 on room air, and she's got the labs which shows the hemoglobin of 84, and she's got low MCV and MCH. White cell count is normal, platelet normal, INR is normal. So my task, as said, that were to take a focus history from the patient and outline the management plan. Anybody would like to have just 2 or 3 pointers? I think I've got Dr. AM. I can, yep.
Hello, yes. So my name is Aisha.
Aisha, okay. Thank you, Dr. Aisha. Thank you for being brave.
Yeah, I really am being brave because I haven't done any study regarding gynae lately.
Okay.
So I'll start with introduction.
Mm-hmm.
Sorry, what's the patient's name? Hi, my name is Dr. Aisha. May I have your name, please?
Okay, let's just say her name is Nancy. My name is Nancy.
Hi, Nancy. Thank you so much for coming today. Can you tell, I just had a look at your entry from the receptionist, and I see that you're experiencing some issues with bleeding down there.
Yes, doctor. So basically what happened is that I had a medical termination of pregnancy through my GP, and I took the medication that was prescribed to me. Now, my GP was quite thorough in terms of telling me what would happen and what should I expect over the course of the next few days. So after I took the medication, I started having bleeding from the very next day. And that bleeding was associated with the lower abdominal pain, which I think was like more like a period-like pain. And the GP said that, look, if you got pain, you can take some painkillers, which I did. And after about 4 or 5 days, the bleeding got lighter and the pain also got better, and I was fine. And I thought after 5 days, there was no bleeding. And I thought, look, maybe it's all finished. When I was in the shower today going to my work, I noticed some fresh bleeding, quite heavy actually, with some large clots, which got me really worried because I felt a little bit dizzy and lightheaded. And my GP had actually told me that if I was to ever experience a very heavy bleeding, then I need to go immediately to the hospital. And she also said that if I was feeling dizzy or lightheaded or finding myself, as if I'm going to pass out, then I need to call the ambulance. So today I ended up calling the ambulance because all of that was happening, heavy bleeding, feeling lightheaded and dizzy, and as if I'm going to pass out. That's why I'm here.
Okay, thank you so much for providing me this information in detail. I'm just going to ask a few more questions to get a better idea of what's happening. Can you tell me if you have experienced any fever lately during the last 2 weeks?
No, doctor, I've been fine. I haven't experienced any fever.
Okay, and during the pregnancy or termination or after, did the doctor do an ultrasound or an examination down there to see the situation?
Yeah, so initially when I had a positive pregnancy test and I went to the GP wanted to confirm because I was insistent that I needed an ultrasound. And we did an ultrasound which confirmed the pregnancies in the womb, if that makes sense. That was done at like about 7 weeks, so about a week ago, or a couple of weeks ago.
Okay. So basically, I see that we had an ultrasound done today, and it shows that some of the clots and products of conceptions are still in the uterus. So basically, what happens is if there is any anything that is left in the uterus, after the termination, that means that the termination didn't occur completely, and anything that remains can cause infection and cause the uterus to be not come back to its original position, and that can lead to the bleeding. So I see that your vitals today show a heart rate which is high, and that can be because of the amount of the blood that you've lost. You also have a lower hemoglobin level, although your blood clotting tests are normal. What we're going to do is we'll need to examine you down there with an instrument just to have a greater visibility, and we'll need to remove any products of conception that are still there. So what that's going to do is it's going to enable us to remove all that is left over in there, and then it will allow your uterus to contract and go back to its original position so that the bleeding would stop. So one of the things that we do for that process is we will also like give you a massage to the uterus, as well as give you some medication, which will enable your uterus contraction. Yeah, so it can have like some tone in it. Additionally, we would also give you some IV fluids to ensure that you have that your heart rate can become normal, and any blood loss that has occurred can make you does not stress your vascular system. I would also recommend a blood transfusion after blood grouping and cross-matching, and then hopefully, like we are very expecting good recovery after this. Does that sound all right to you?
So, doctor, why do you think that I felt lightheaded? And because I feel completely fine now. I've got no pain. The bleeding, I've checked now, it's actually almost gone. So why do I still need to have a blood transfusion and all of those things?
So basically, because you suddenly had like a heavy bleeding, so it can sometimes take the vascular system to like deal with the immediate blood loss by accommodating itself. And so that's why, because it's been some time, and that's why you're feeling a bit better now that the bleeding has stopped. But I still see that your heart rate is high. So if you have any concerns, we can, just not give you the blood transfusion yet, and just give you IV fluids, and then see if over the time there's improvement with iron supplements. Yeah.
Okay. All right. I mean, that's okay. Also, do I need to be admitted to the hospital now that I'm feeling okay? Because I've got quite a few things to do at home, and I've got a very important work day tomorrow. I've been off sick lately because of this problem number of times, and my boss is really upset. Can I go home, or?
I'm happy to give you a work like off for 2 days from the hospital, from the workplace, because we are going to like do a short procedure. So I think it's important that we do keep you here at least overnight and don't send you back until we are confident that you can manage at home.
All right. Thank you very much, doctor. Thank you.
Thank you.
Thank you, Dr. Aisha. That was remarkable. How do you feel? How do you feel about this scenario? Was it as comfortable as you thought it would be, given the fact that you have not practiced the gynae stations for a while?
I just, I thought about what it could be, and I just stuck to it.
Yes.
So, yeah, I mean, if it was in cases of DDs, I couldn't think of a lot of DDs apart from what we just discussed.
Yep.
Yeah.
Yeah. All right. No, overall, very good effort. You speak very nicely, and I'm sure that look, your communication is quite clear, and from that point of view, you get full marks. However, this scenario is deceptively nuanced. There's quite a few things going on in here. So even though it lends itself to a simple PV bleeding kind of retained product of consumption, and we almost think from our mind that look, there's some dizziness, there's some presyncope, there's a low hemoglobin, probably a borderline tachycardia. I won't be worried about that too much. And this patient needs admission, this patient needs DNC, this patient needs all of that. But as I said, there's more to the history which were not established. So I was expecting quite a lot of questions from those important points, because this is, as I said, it's a real case which I saw only 2 days ago. And the management, when I discussed with the gynae, was exactly based on the Ranscock guidelines of PV bleeding in terms of medical termination of pregnancy and some Australian family medicine practice. So this is the other point which I'd like to highlight, guys, and this is for everyone. I think by majority of people have got a very good sound knowledge of particular condition or particular way of managing things. But I think where we as IMGs lack is lack of understanding of how the local guidelines work. And that's where, local graduates always are important, because they've been in the medical students in the same area and same country and same hospital. So they know how to manage those cases and assess those cases right through their training. Now, we worked in a different system. When we come to a new system, we don't know how, there are EPAS clinic, there are outpatient services, there are incorporation of GP practices into this management plan. So there's a lot going on, and a lot of ways of managing the same thing, which would have otherwise required an admission, can be done here in with several different ways. But anyway, coming back to the basics. Now, the first task was to take a focus history from the patient. And I think that's very important, to take a history which is very descriptive. So I have made some points on that history, that when I'm making points that this history needs to cover the focused history and focused tasks of management. That is me cognitively telling myself that this is what I need to do. I need to check for the infection system, which Dr. Aisha did. I need to also roughly try to quantify the hemorrhage, which might be number of pads changed, number of times that she had, bleeding ongoing, or associated presyncope, lightheaded, dizziness. Any previous obstetrics and gynae history? I mean, I deliberately did not give you any previous gravity or para. That would be important. If she's had any previous miscarriages, what her normal cycle is long like. Any allergy history is very important, because if the bleeding gets heavy, if I want to give her transfusion, I need to know about the particular allergies. Coagulopathy, even though the INR is normal, it's always good to know the coagulopathy. And also, one of the things which I've deliberately mentioned here is the anemia. And if you look at the scenario, the anemia is low MCV and MCH. Now, this cannot be acute bleeding. So this hemoglobin of 84 is actually deceptive. This is a chronic bleeding, which has been going on for a while. And that patient actually told me that she was meant to be getting an iron infusion from that point of view. So that is important, not to confuse this point as a new bleeding as opposed to the chronic bleeding. So when I took a history from that patient, she told me that this morning she was meant to be getting an iron transfusion because she suffers from iron deficiency anemia. So I think in history, this has to be established. This had to be established, which was not established. Coagulopathy was not established. Infection, yes, you ask about the infection, but I think I would like to have a better detail into infection. Has there been any fever? Has there been a feeling of being unwell? Has there been any discharge from down below? Has there been any pain or any offensive smell? So just trying to exclude an infection and saying, oh, have you had any symptoms of infection or fevers is not in, you have to be specific. Have you had increasing abdominal pain? Have you had any PV discharge? Have you had any foul smelling discharge? Have you had any symptoms of lightheadedness and dizziness throughout this process? Because infection cannot just happen like that. It would have slowly and gradually developed. And then when you're asking about the coagulopathy, do you suffer from any bleeding condition which makes you bleed more? Some of those conditions may include, thalassemia, hemophilia, or any of those conditions. Have you been to a hematologist? And then the patient would say, no. So that's demonstrating to the examiner that you've gone through each of those differential, which are very important to reverse in this case. Okay. And then, yes, I have actually picked up one thing in your bloods, which identifies that you're bleeding, your hemoglobin is actually low, but at the same time, some of the other blood tests are showing that it might have been low for a longer time. Have you ever heard about iron deficiency anemia? And the moment you prompt that, the patient will say. So that's what I was saying, that ask about the history specifically, if you have to, that have you got any bleeding issue or any anemias that you know of? So that's the specific information that need to be tweaked out. And that's why I have specifically mentioned low MCV and MCH. Can you imagine like why low MCV and MCH has been mentioned in a clinical scenario when there's an acute bleeding? There's practically no sense. I mean, if I want to be deliberate and open about it, I'll say the patient has got a known history of iron deficiency anemia. So this hemoglobin can be deceptive. So this patient does not actually need blood transfusion. Healthy, young, fit and healthy patients who are hemodynamically stable, they need iron transfusion, iron replacement therapy. That's what we do for PV bleeding as well if they bleed heavily. Normally, we refrain from blood transfusion unless and until they become hemodynamically compromised. So that's the point I'm trying to highlight. So in terms of my history, I will go through infective symptoms, hemorrhage question in terms of changing of pads. Has she felt any associated lightheadedness, dizziness? Is the bleeding getting heavier or is the bleeding getting lighter? Any previous obs and gynae history, allergy history, coagulopathy history, bleeding history, blood group, iron deficiency in particular, or any of the other anemia conditions. Okay. And then in terms of management, which is the task number 2, outline the management plan. There are actually 2 tiers of management. And looking at when that day I went and read the guideline myself, they were saying that the patient who are stable in the bleeding is reducing. You can manage these patients as an outpatient and can book them in for dilatation and curettage for the return products of conception. So if they're not septic, if they're not having an ongoing hemorrhage, these patients can be observed overnight in a short stay unit, followed by a gynae review, and the gynae can decide to discharge them for them to be managed as an outpatient. So that would be some sort of an understanding which the people who have worked back in a different country would not know, that these are the way of managing the same case. So this is a bit more nuanced, but a bit more typical. And in terms of the specific guideline, I'll tell you that the diagnosis, if the patient has got persistent heavy bleeding, I'm reading the guideline now, ongoing crampy abdominal pain, and or the ultrasound findings of echogenic material within the uterus, the initial management is towards the stability of the patient and stabilizing the bleeding. If the bleeding is settling and the patient is stable, the guidelines say expectant management, that is waiting, may be appropriate. That's Ranscog website guideline on medical termination of pregnancy. Medical management, if the bleeding is heavy, but the patient is stable, a repeat dose of misoprostol, that is 400 microgram. Now the patient is saying the bleeding is actually getting lighter. So we don't even need to give her misoprostol from that point of view. So what are the indication of surgical management? Surgical medication are indicated, obviously, no price guessing, heavy bleeding, sepsis, and not responding to the first line treatment of IV fluids management, pre-syncope, lightheaded, ongoing heavy bleeding, there's an infection, high fever, then you need to take the patient urgently to the emergency theater. What Dr. Aisha was talking about, uterine atony, that's in a different context. It's a postpartum hemorrhage in which you do the uterine massage, and it's a completely different issue, not related to this one. Uterine atony and uterine massage, it's a different guideline. So try not confuse those, but overall, I would say a good management from that point of view. And obviously, if you are suspecting an infection, then you need to cover the patient with antibiotics as well. So overall, the guidelines say patient preference. If the patient wants to go home, you would still mention as a part of your duty of management that, look, Right now, I'd like to observe you and get a gynecology consult. If the gynecology and obstetric registrar want to manage you as an outpatient, as you prefer, you can go home. But that's after the review. That's actually what I practically did as well in the hospital. And then you can be followed up in the EPAS clinic, Early Pregnancy Assessment Service clinic, in a week's time to see how things are progressing. Maybe, whatever happened, and you will get another bleeding and everything would clear out. So that's the expected management. And we may have to repeat an ultrasound and see how things are progressing. In the meantime, obviously, the red flag advice is if the bleeding gets heavier, you are experiencing the symptoms of dizziness, lightheadedness with the heavy bleeding, or you're experiencing any fever, then I would encourage you to come back to the hospital immediately or call the hospital. Does it make sense? And the patient would be happy with that. So yeah, that was the point which I'd like to add from the point of view of how these scenarios can often look very cute and simple, but they would have many issues surrounding them. Dr. Nisak, have you got anything to add? If you may, please.
Yeah, nothing much. You have covered pretty much everything.
All right. I just thought that I'll write the scenario because PV bleeding is very common ops and gynae scenario. I don't think that there hardly be any exam in a year where the PV bleeding is not addressed, but to create a little bit of a twist in which the history, if not taken completely, would not lead you with enough information to make up a thorough management plan. So this is precisely the way where the history is very important. And knowing the local guideline as per RANSCOG in terms of medical termination pregnancy is just so crucial. I believe Dr. Nisak has or would like to talk about a case as well. Is that?
Yeah, absolutely.
Yeah. All right. Okay. I will stop sharing my screen and I will get Dr. Nisak to share his slide if that might happen. Can you share the slides now, Dr. Nisak?
Right. Can you see my screen, guys?
Yes.
All right, perfect. Okay, so let me give you a little bit of preview before we discuss this case. This case might look a little bit more simpler, right? So I prepared a case based on the recent recall. Okay, and this is the exact information that you will be getting based on the recall. And I wanted to give you guys a little bit of more idea on how to work around the recalls and how to get your mind working and start the thinking process. Okay, so let's dive into this particular scenario. So you are a junior doctor working in ED. A 42-year-old woman presented with a acute right upper quadrant abdominal pain associated with the nausea and fever. Okay, so now this is a lot less information in compared to what you actually get in the exam. Okay, but in the recalls, you might have even less information than this. Okay, but your history, your task, if you can see your focus history for 4 minutes, you have to ask the physical examination from the examiner and you have to explain the diagnosis and the differentials, okay, to the patients. So if you can see from the previous case, as Dr. Rizwan discussed, the structure is changing a little bit. Okay, so we also have to modify a little bit. Now, in the first 2 minutes, what should be your thought process in this particular thing? Okay, so what I would suggest is to have a complete framework on the history, like what should be you be jumping from and what are your list of differential, because in those 8 minutes that you're working towards the case, you will have those muscle memory to work with you. Okay, you will not have even time to think what's going on in the case and what the patient is giving you if you don't have enough diagnosis differentials already in your mind. Okay, now what we follow in all the history structure, as Dr. Rizwan mentioned, it should be formulated, it should be in a systematic methodical manner. All right, so we always start with assessing with the open-ended question. Let the patient speak. Okay, let the patient give the entire story, what, and so we can also get a little bit idea what actually we are dealing with. Okay, once you are done with that, we'll start with an chief complaint assessment. Okay, in this particular case, you can see there are 3 chief complaints. Okay, abdominal pain, nausea, and fever. Now, at certain point, you might feel that it's just 4 minutes history. How we can complete everything in time? Okay, but that's the thing. This is the key point for your particular case, and you have to assess all these 3 complaints very nicely. Okay, so when you are using abdominal pain, you can use any type of mnemonic. Okay, either Sicora, Socrates. The only thing is you should be able to assess each and every factor of the abdominal pain. Okay, it's basically the site. Site is already given this time, so you don't have to worry about that. Then the characteristic of the pain, whether it's dull, sharp, stabbing type of pain. Okay, does it have any kind of association with any kind of food, like taking after fatty food? Does the pain increases? Is the pain traveling anywhere? What is the quantity of the pain, like on a scale of 1 to 10? Can you describe or rate the pain? So if the patient is under a lot of pain, like 5, 6, 7, okay, we can offer the painkiller. Okay, once you're done with that, we'll jump into the fever, we'll jump into the nausea to get an assessment idea, like whether the patient having any chills and rigors, if the patient has taken any medication, and whether that's happening or helping or not. Okay. Once you're done with that, that's your first component of the history, open-ended question and your chief complaint assessment. Then we'll move on to the second component of your history, that is your differential diagnosis. Okay, in the right upper abdominal pain, okay, what we can think that it can be something related to the liver, pancreas, or even a gallbladder, right? So that is the main thing that we'll be assessing first. Okay, ask for yellowish discoloration. You already asked for the association for the any fatty food, that will give you assessment or the idea about whether this is something that we're dealing with the gallbladder causes. Okay, ask about the past medical history, whether the patient has experienced this type of pain before, or does the patient have any kind of history. Then we'll move on to generalized abdomens. Okay, like what are the little bit rare causes that can give you this type of pain? Is the right-sided lower lobe pneumonia? Okay, along with that, peptic ulcer, gastroesophageal reflux disease. If we go into a more generalized thing, which can show multiple symptoms, is like IBD, inflammatory bowel disease, along with that bowel cancer. Okay, even though it's not very specific to the right upper quadrant, but still is part of our differential. Okay, after that, we will be moving on to third component of the history, that will be your closing statements. Okay, so at that point, we will be asking some general questions. Okay, if the patient is a smoker, if the patient consumes alcohol, if his patient is on any kind of medication, along with that, any family stuff, similar type of conditions as well. Okay, that will give you overall idea what you're dealing with. Let's say if the patient is a chronic alcohol user, okay, he drinks around 1, 2 bottles daily. So we are definitely worried about the liver failure, cirrhosis. That's what you're worried about. So this is the approach that we want. Now, talking about this particular case, this case, I will show you another slide. So this is a type of a card that will be given to you, given to the role player actually. Okay, so they will have a proper framework on how to respond to each and every question, how to give you the findings. Everything will be guided to them. Okay, now the reason why I'm showing you this particular card is so that you personally can get an idea as well. Okay, like how should we work on the questioning and everything. Now, in this particular case, if you can see, the patient is having pain for 12 hours. It was a sudden onset pain. Pain is constant and it's 8 out of 10, so quite severe. And in sense of radiation, it is radiating to the right shoulder and the upper back as well. And it is getting worse with the fatty meal. Okay, now at this point, we are sure that we are dealing with something related to the gallbladder. Okay, but still we don't have a diagnosis. Okay, we are just working towards a provisional diagnosis. There comes the task number 2. Okay, ask the physical examination from the examiner. Okay, that's when you have to be very smart. Okay, we don't have to go into detail, we don't have to explain anything to the examiner. We'll thank the patient that thank you for providing me the information, just give me a moment, I will talk to my examiner. You change the frame, start asking the question to the examiner. All right, we'll start with the general appearance. We'll start with the general appearance, we'll check the vitals of this particular patient, and then we'll move on to a core examination, okay, which is our abdominal examination. In that, we'll be again using that same methodical framework, okay, because in AMC clinical, we still have the marks for the organization and the formulation. Okay, so we have to get that score as well. So we'll start with the inspection, palpation, percussion, auscultation, and then some few special tests. Okay, that will be your Murphy's sign over here, because patient is complaining about the right upper quadrant pain. Okay, let's say if the patient has some other pain, for example, right lower quadrant pain. In that case, our first provisional diagnosis that comes to our mind is the appendicitis, right? So in that case, our special test will keep on changing. We'll be moving on to the Sua's sign, or the obturator sign, or the Murphy's sign. Okay, but that is not relevant over here. So we won't be wasting our time by asking all those things. Okay, so once you ask about the Murphy's sign, the examiner will give you, yeah, it's positive. So there's your diagnosis. It's an acute cholecystitis case. Okay, once you've got your diagnosis, still you have to complete your entire structure of the physical examination. If anything is remaining, if you are suspecting that these office tests are necessary, like urine dipstick test or the blood sugar level, which are not much relevant over here. If you think that they are relevant, just continue by asking that, get the information from the examiner, again thank the examiner, and move your focus to the patient, where we'll be moving on to our last task, that is your third task. At this point, you will just be having 2 minutes. Okay, if you can calculate 4 minutes for the history, it will take around 2.5 minutes, 3 minutes for the physical examination. Okay, based on how much speed you can get. So now you understand what time strain that you're feeling. In 2 minutes, you have to explain the diagnosis. At the same time, you have to give a lot of differentials as well. Okay, so at that point, as Dr. Rizwan just told us, you have to use a very simple layman terms. Okay, do not try to complicate things for yourself or for the patient as well. Okay, so if you can go into the explanation over here. So based on the right upper quadrant, upper abdominal pain, fever, nausea, and the examination finding, including a positive Murphy's sign, most likely you have a condition called as acute cholecystitis. Okay, what does that mean? This means your gallbladder is inflamed, most commonly due to a gallstone blocking its outlet. Okay, as simple as that. It will take hardly 25-30 seconds. And then we immediately move on to the differential diagnosis. All right, that I was thinking about the other conditions like biliary colic, ascending cholecystitis, or hepatitis, pancreatitis. If you still have time, you can go into the other differentials, as I told, the rare ones like right lower lobe pneumonia, IBD, colon cancer, still relevant. Okay, you can still start on mentioning, try to make as long at least as possible. Okay. Now, the reason why we discuss this particular case is if you can understand the history and the formulation completely changed, right? In the first two cases that Dr. Rizwan discussed, we were focused more on the management and the complication that the patient might be having from that particular condition, so that we can manage that patient particularly and very nicely, okay, without missing on anything. But in this particular case, management is not our task. So we have to focus more on the differential diagnosis rather than the management point of view. Okay, so that's the thing with the structure, with the task, your approach should change from case to case.
That's very
All
good,
right,
Dr.
so
Amy.
this is, yeah.
That's very good.
Yeah,
Please carry on, carry on.
Yeah, absolutely. I was just about to hand over to you. Yeah, please go on. Yes, sir.
So one of the things which, in terms of working diagnosis, if you bring back to that slide, Dr. Amy, Nisak, yeah. So working
right.
diagnosis. So based on the right upper quadrant, right abdominal pain, fever, nausea, and examination findings, including a positive Murphy signs, the most likely diagnosis acute cholecystitis. If the examiner is asking, maybe this statement is quite appropriate. If the patient is asking, I would very simply, based on the history of your tummy pain, fevers, and feeling sick, and my examination findings, I think you're suffering from a condition called cholecystitis, which means infection of your gallbladder. Now, if you know, gallbladder is a tiny sac which is beneath your liver, and sometimes it can get infected and inflamed because of the stones or because of the infection. Keeping it very simple, on the lines of keeping it very simple. Try not to using overt medical jargon. And the patient may then ask, oh, I was worried about pancreatitis. I was reading it up. Could it be pancreatitis? No, it's unlikely based on the blood tests. Oh, I was worried about cholangitis, or I was worried about more nasty infection involving the liver. And you can say, look, it's unlikely because those are the patients who normally would get discoloration of the skin as yellow. So it's an unlikely diagnosis. Or you can say that it's an unlikely diagnosis of the liver itself, because there's no jaundice, there's no blocking of ducts, and the numbers are not looking nasty from that point of view. Well, I think you should refrain from using the term nasty, because it just confuses the patient even more. But just be very affirmative that I don't think that's the case, because the numbers are looking fine from that point of view, making sure that it's not a cholangitis, but the infection is now confined only to the gallbladder, or it's still at the gallbladder level. But that's about it. I think that's all the cases that we've got for you today. So thank you very much for attending. If anybody's got any questions, more than happy to answer now, or otherwise we'll share the recording. Any questions from anyone?
Dr. Rizwan, I got one. So in this particular scenario, the right upper quadrant pain, I was just thinking to include the heart-related conditions like angina or MI. Would that be relevant in this case, because Murphy's is positive, and if he neglect that one, would be okay, or how is it? I mean, I'm not too sure.
Yeah, Dr. Nisak, what would you say? I've got my own prejudice, but I'll because it's Nisak's scenario, I'll get him to
Yeah,
answer first.
absolutely. Yeah. Okay. So that's actually a valid question, and that's how we usually deal with this type of cases in the routine practice. If we are getting something positive, we don't work on something which is much relevant over here. And we're absolutely on point, like the angina, lower lobe pneumonia, that but not are much relevant, right? In this particular cases, but there's the thing, like we are getting score for these things in the AMC clinical. All right, and this all depends on your second or the third task. Okay, what is your task, whether they're asking for the management or whether they're asking for the differentials. Okay, so once you have ruled out all the relevant differential, I will still recommend going and asking for that least relevant differentials over here. But let's say if your task they are changing a little bit, okay, they're asking for a management rather than the differential list. Okay, in that case, I won't go towards that particular direction, and I will be focusing on more towards the complication and the medication or past medical history, which might interfere with our management plan.
Good point. And also, I'd just like to add on the same theme that we've talked about today is trying to keep things simple. And the scenario lend itself with an abdominal pain, tenderness, right upper quadrant abdominal pain or right-sided upper abdominal pain, along with the fever. The AMC is not trying to trick you to make you think with an abdominal pain scenario to think about the acute myocardial infarction. That's not the way. In terms of differential, you can quickly exclude that um, by number of different mechanisms, that if there's any associated chest pain, when it's unlikely to be an acute myocardial infarction because there's a component of chest pain. If they want you to think about an acute myocardial infarction or inferior myocardial infarction presenting an acute AMI, they won't give you fever. They won't give you right upper quadrant tenderness or positive Murphy's sign. So try not complicate things from that point of view. Keep your differential isolated to the liver, pancreatitis, cholangitis, high up retrocecal appendix. Try keep it simple, and you won't confuse, because there's only people know and examiners know there's a very limited amount of time, and you can only establish what is there. There are only 3 or 4 differentials that you can work up with. And there's no point going on to the chest. And then before you know it, there will be, oh, is there a rash? Could it be shingles? Could it be musculoskeletal chest pain? Could it be aortic dissection? Oh man, we're going into rabbit hole of things. So try keep it very simple, try keep it logical, and you'll do fine. Any
Thank
other question, or we just end it here maybe?
Just a question regarding asking examiner about the physical examination findings. So is it going to be the same whether it's an online exam or the in-person, or like in online we'd ask the examiner for the findings. So if it's in-person exam, will we need to elicit the findings, or we can still ask the examiner for findings and they will tell us this is the examination result or the result of physical examination?
Dr. Nisak, would you like to address that?
Yeah, absolutely. I would take that question. Okay, first of all, the online exam and the face-to-face exam are very similar, but yet a little bit different. Okay, the first and the most differentiating feature is asking the physical examination. Okay, so up till now, so far in AMC clinical online examination, they have not introduced that particular task. Okay, like asking the physical examination from the examiner. Once you go towards that particular path, you will get a entire list of physical examination that are positive or normal on your screen. Okay, but talking about the other part, going for a face-to-face exam, okay, you can get a physical examination 2 ways. Okay, the first one, same as clinical, the examiner will hand you a pamphlet or a paper in which all the examination finding will be written. Okay, the second task is the one that I'm talking, is the get the physical or ask the physical examination from the examiner. Okay, in that particular case, the examiner will only give you the physical examination finding that you're asking from the examiner. Okay, let's say you're asking the examiner, can I get the physical examination? I would like to check the general appearance of my patient. Is my patient having any pallor or any signs of jaundice, any signs of dehydration? Okay, if the patient will respond in yes or no only, okay, the patient will not give you the additional finding which you have not asked. Okay, so this is the difference. Hopefully that answers your question.
Yeah, that's
Yeah,
completely right. Yeah.
Yeah, that makes a lot of sense. So basically, they wouldn't ask us to do the examination on the
No, not at all.
patient. So it will just be like verbally asking.
Yeah, absolutely.
Yeah.
Yeah.
Thank you.
Yes, so thanks for explaining the this again in a very good way. And I think majority of the exams are now face to face. And one of the things which I remember in physical examination, even in my time, was that they will only respond to the things that you will ask.
Yeah.
So having a structure in your mind is still very important. Starting with the general physical examination, starting with the inspection. On the inspection, are there any surgical scars, any erythema, any rashes, or anything like that? Palpation-wise, is there tenderness in the right upper quadrant? Is there tenderness in the left upper quadrant floor or anywhere else on the body? Is there any renal thing? So I think from that point of view, you still have to have a structure rather than blindly throwing out questions and having yes and no.
Yeah, absolutely.
All right. Okay. Okay. There's a patient, there's a question from someone. I'll just go through that. What if it's a real patient instead of an actor? I believe it's an unlikely case to have an acute cholestasis febrile patient as a real patient. They would largely be an actor. First of all, it's not ethical, and it would be hugely uncomfortable if you got an inflamed gallbladder and hundreds of people coming and examine you back and so I don't think. Do we get cases to perform the physical examination? Do we get cases? What does that mean? Nisa,
Yeah, absolutely. I think the doctor is over here is asking whether we actually get the real cases to perform the physical examination rather than asking. Okay, so those are the pure physical examination cases in which you have to do 6 minutes of physical examination and then you have to explain the diagnosis and the differential. Okay, so this is an entirely different thing from this history taking cases. But yeah, they definitely ask those type of performance of the physical examination cases as well.
so the question again is been asked. I meant for the counseling cases, would you get real patients? Again, I think for the low fidelity exam as AMC clinical, it would be unlikely to get a real case. For high cases, if they are RACP exam, where obviously they're trying to mimic the real situation as close to reality as possible, for often a very long and convoluted diagnosis, because there is a long case, there's a short case, then they would have a patient with, certain cranial nerve palsies. You may get that in high-end exam, but in AMC clinical, I think it's unlikely. I'm not sure what the trends are going to be for 2026 though, if they're going to have more actors or what are the cases. They may have some cases with the chronic, cranial nerve findings, but that is yet to be decided and seen. And maybe for counseling sessions, if you think, I'm not sure about what particular case of real patient would lend themselves to be more appropriate in counseling way. Yeah, so that is, I think, variation as case per case basis. Anyway, thank you very much, guys. Thanks for taking the time out of your busy Sundays. I know it's always very hard to take a time and sit for that long on a Sunday evening, but thank you very much. And if you want to join our classes and session, we'll be starting our sessions very shortly, AMC Clinical, and you're more than welcome to join. We have still got 2 or 3 places left on it, and you get an access to the portal in which all the previous courses are there, all the reading materials are there, and you get it immediately as you join. And we are doing a cluster-based approach, which has got a theoretical as well as practical components as well. So thank you very much and all the best. And I hope to see and work with you soon at some point. All the best.